And we are live. Good evening, everyone, to India, and good morning to everyone out there in the West joining us from the United States. Welcome to today's joint IASO-SSO webinar. Uh, it's part of the Masterclass series, which shortly Dr. Rao will tell you about, who are new to this webinar. Today's topic is going to be pancreatic cancer. I invite IASO President Dr. T. Subrameshwar Rao for his welcome address.
I would call today a great day for academics in surgical oncology world over. Both IASO and SSO have always dreamt to conduct joint webinars for quite some time now. Today is that day wherein this landmark event is being unfolded. Lots of efforts have gone into this. The Masterclass series started 6 years back during the COVID, and then it continues unabated over years, every fortnight. Appreciate the leadership of IASO and SSO for being responsible for this event today, and we hope to continue this forever. Special appreciation for Dr. Chandrakant Are for all the spade work that he has done to make this happen. We acknowledge the presence of Dr. Sarath Desai, immediate past president, and Dr. Chandra Mohan, president-elect, in the panel group. I welcome all of you for this very important webinar. We have a very eminent faculty. Dr. David Bentram is a professor of surgery, Robert H. Lurie Comprehensive Center of Northwestern University, Surgery Service Chief, Jesse Brown VA Medical Center. Welcome, Dr. David Bentram. Dr. Chandrakant Are is very familiar to all of us. He's a JL and CJ Warner Professor, Surgical Oncology and Global Health CEO, Global Forum of Cancer Surgeons at the University of Nebraska Medical Center. The Indian faculty includes Dr. Ramakrishnan, who is a senior consultant surgical oncologist working for the Integrated Cancer Care Group in Chennai. Dr. Manish Bhandari is a professor, Hepatobiliary and Upper GI Services, Department of Surgical Oncology at the ACTREC Center, part of Tata Memorial Hospital, Kharghar, Navi Mumbai. Two examinees who have volunteered. The first one is from Chennai, Dr. Nivedita Putala. She's a final year surgical oncology resident at the Cancer Institute, Adyar. Dr. Amit Nehra is from New Delhi. He's a final year surgical oncology resident at the Max Super Specialty Hospital, Saket. Welcome you all. Request Manish Bhandari to take the event forward.
Yeah, so Dr. Manish, over to you in 2 minutes. I invite Dr. Chandrakant Are for a short brief from SSO.
Thank you, Dr. Shukla. I serve in two roles. I've been involved with SSO for a very long time, and I also serve as the overseas coordinator for Indian Association of Surgical Oncology. We all have many career highlights, but for me, one of them is to see this amazing relationship between IASO and SSO, which started as a tiny seed back in 2009. And to see where we are today, as Dr. T.S. Rao mentioned, this is historic for us to do this. And we know that this is the first of many that's going to happen. What's also relevant that many of you know, but need to point out that IASO and SSO are maybe two of the 3 or 4 largest surgical oncology associations in the world. And they serve as global leaders, and not just for their region, but also for the world. And I do want to make a special mention of many of the leaders that are on this call from IASO who have become good friends and who have been extremely helpful in coming this far. To start with Dr. T.S. Rao, I see Dr. Chandramohan, I see Dr. Sharad Desai, and yourself too, Dr. Shukla. Over the years, starting in 2009, we never knew that we'd come this far. So I think this is a great day, and it's the beginning of, I think, many, many, many more good things to come between these two large and fantastic organizations. Thank you.
Thank you, Dr. Ari. Explaining the format shortly about the webinar today, it's divided essentially into three parts. The first part will be for an hour, and it's the mock examination. And essentially what's happening here is we have two surgical oncology residents who will be interviewed on their management knowledge and skills for about pancreatic cancer by a set of 4 faculty. One of them, who we can see in the red here, is the moderator, Dr. Bhandare, who will himself present the cases. It's he who has prepared these case capsules, these scenarios, and all the faculty will interview these two based on them. This will be followed by 2 talks by our faculty, and lastly, we have a short Q&A session. So if you have any questions that are not addressed by the discussion, please put them into the chat box or the Q&A. We'll take it from there and ask our faculty in the end. Small instructions to the participants here. For the examinees specifically, we request you to give to-the-point answers. It helps us save time. No candidate is ever expected to know all the answers, so there's no harm in mentioning if you don't know answer to a particular question. Mention it, it saves us time and maintains the flow. And please keep the habit of catching the hints that our faculty will be giving you throughout this session. To our moderator, Dr. Manish, we request you to ensure that the examinees are addressed by their name to avoid confusion who's supposed to answer. I request the other examiners also to make sure. The 2 examinees today are Dr. Nivedita and Dr. Amit. To the examiners, because this is not a real interview or an exam, if our examinees give a wrong answer or they fail to answer a question, we request you to give the expected answer to your question so that everybody who's attending it live or viewing this later gains from this. For our live participants, thank you for logging in. Please post in your inputs. Attending it live gives you the best opportunity to clear all your doubts. With this, we request Dr. Manish Bhandare to share his screen and proceed with the first part, which is the mock examination.
Hello.
As he loads his screen, I will put a short message on the chat box 10 minutes before the first 1 hour is up. Thank you.
Thank you, Shrijan. Am I audible and is my screen visible?
Yes.
Yes.
Okay, so welcome everyone. It is my privilege to be part of this distinguished panel for the first IASO-SSO Masterclass series. And I think it's great that we have chosen the topic of pancreatic cancer to begin with, because pancreatic cancer remains to be one of the most challenging disease to treat within surgical oncology. And what I'm going to do today is to present 2 of the localized cases of pancreatic cancer, that means non-metastatic cases. And we will go through what is the standard line of management of these cases. And not only that, but also the nuances of how and when different approaches are required in managing this kind of a disease, which has a lot of details in terms of technicalities, patient factors, tumor biology factors, as well as when it comes to surgery, the technical aspects. So without further ado, I'll start with the case presentation. And as we discussed just before starting, I'm going to start and wait. And please, Dr. David, Dr. Chandrakant, and Dr. Ramakrishnan, please feel free to stop me so as you can ask questions to Nivedita as well as Amit. So the first patient that is going to be presented is a 62-year-old gentleman from Maharashtra, which is the western zone in India, who presents with chief complaints of abdominal pain for a month's duration, along with vomiting and high-colored urine. As a standard practice, as we know that the history of present illness, once it is presented, the duration has been about 1 month. The dull aching pain was observed in the abdomen, which was insidious in onset. This was associated with vomitings and the high colored urine, all three of the symptoms which occurred together. There was no history of fever or weight loss or any other altered bowel habits. When we dig into the past history and family history, known hypertensive, history of some spine surgery a couple of years ago, but probably appears unrelated to the present illness. No significant family history, no personal history at this date. I'll go ahead with the case presentation further. Okay. So the general examination again is standard. I think we will not go into these details because as a part of the IASO-SSO Masterclass event, we want to discuss further events, but broadly on the general examination, apart from icterus, there was no other positive clinical finding, abdominal finding, or a systemic finding. At tertiary centers, we always get patients with some investigations which are already done before. Ultrasound abdomen was performed where there is a gallbladder sludge, a dilated common bile duct, as well as main pancreatic duct is noted. And there is an hypoechoic lesion around distal part of the bile duct. And it mentions that it is a suspected periampullary tumor on the ultrasound report. MRCP was performed, which showed a dilated common bile duct, abrupt cutoff with an abrupt cutoff, and upstream dilatation, which we call it as IHBRD, intrahepatic biliary radical dilatation, along with a head pancreatic lesion, main pancreatic duct dilated, as well as bile duct. That means a double duct sign. I would ask a question here at this state to Nivedita, that is this sequence of investigations appropriate, or would you ask for investigation in a little different ways? You see that there is an ultrasound and MRCP is being performed.
Yes, sir. Since already patient had come with USG and MRCP, but I would still like to get a contrast enhanced CT with pancreatic protocol, sir.
Okay, so had this patient reached out to you, would after the ultrasound abdomen report, would you have directly asked for a triphasic or a pancreas protocol scan, or you would have asked both MRI as well as a triphasic CT?
So I would have asked for a triphasic CT, sir.
All right. Okay, so can you elaborate quickly that what exactly means a triphasic CT scan? And what do we look for when we are suspecting a pancreatic lesion in this scenario?
So we would, the triphasic CT, the contrast which is used is non-ionic iodinated contrast.
Sorry, while you speak, I'm going to quickly run the images so that we save time, but you please continue to mention that what exactly the triphasic CT scan is helpful for.
So we are interested in two phases, the pancreatic parenchymal phase and the portal venous phase. And we give a non-ionic iodinated contrast, and we take a CT of 0.7 to 1 mm slice thickness. And the injection is given at 2 ml per kg at 3 to 5 ml per second. The contrast is injected. And we look for the early arterial phase, late arterial phase, which is the pancreatic parenchymal phase, and the portovenous phase. So we would look for any, in the early arterial phase, we look for any hypervascular lesions if present. And in the late arterial phase, we look for the any enhancing lesions in the pancreatic parenchyma. as well as the CBD, the duct, as well as the liver, if any other lesions are present, sir.
Nivedita,
And also if there's any lesion, would also see the relationship to the venous as well as the arteries.
Yes, Dr. Chandrakant.
yeah, just I think you're correct, Nivedita. Maybe it's a different terminology. The triphasic that we allude to is an arterial phase and a venous phase and a delayed phase. And you're right, in those three phases, you see different things, but the contrast that you said is given at a certain volume per minute is all variable depending on the institution. But in general, Dr. Bandari, is that the standard terminology? There's an arterial phase and a venous phase and a delayed phase?
Yes, that's true. What we also specify is a pancreas protocol triphasic, which makes the phases slightly different. So it has an early arterial phase, a late arterial or a portal venous phase, and a delayed phase, which is a venous phase, essentially. Dr. David.
Yes, just a comment. Dr. Bandari mentioned, the patient had had an ultrasound. I think that's reasonable. Classically, it's painless jaundice. The patient didn't have any fever, so that tips you off. It might be a malignant process, but there was some abdominal pain. So I think the ultrasound is an efficient way to sort of put to bed the stone disease and evaluate a little bit for that. Look for pericholecystic stranding and things. And then I agree with Navita that I like the triphasic CT scan. I would mention the value of a chest portion because, second most common site for advanced disease, but otherwise I agree with everything.
And one other point of relevance, we always teach that it's painless jaundice, but for those of us that have done it for a while, there are quite a few patients that we see that have pain. Now, in this patient, it says epigastric pain, which is not bad, but you need to differentiate that with back pain. If they say it is epigastric pain boring into the back, that's usually not a good sign because that means the tumor may be involved in the celiac plexus. That's the reason why we do the celiac plexus block. So while many patients present with painless jaundice, when they have pain, even before you get to a CT scan, if the patient tells you that the pain is radiating to the back or they have boring back pain, it will give you an idea, could this be an unresectable pancreas cancer?
Absolutely. So along with the imaging, of course, I will show the CT images as well, but the lab investigations, again, I will not read out everything here, but essentially you can make out that there is slight elevation in the total leukocyte count, 12.69, and the total bilirubin level is 16.8 milligrams, with elevation in the AST, ALT, as well as the alkaline phosphatase level. That means the liver enzymes are high, marginally high, and the alkaline phosphatase is also high. Everything going with the obstructive component of the jaundice. The PT-INR is relatively maintained with slightly low serum albumin levels. At this stage, what would be the next step in management? I'll quickly run the CT image also here, which also shows the same what we had seen in the MRI. And maybe I can ask Amit to quickly elaborate what we see here in this CT. Amit?
Yes, sir. So this is a arterial phase of pancreatic protocol CT. We can see the uptake of the artery and SMA uptake. No involvement of the vessel, sir.
Yeah.
And stent can be seen, sir, in situ, in CBD.
So this already happened before the scan was performed in between the MRI and the CT, that the patient did undergo stent placement for the jaundice. And this is the venous phase. Amit, can you
Yes, sir.
elaborate on
Yes,
that
sir.
also? What is it differently that you see in venous and arterial phase? Just quickly, if you can mention.
Sir, in venous phase, I will see that if there is portal vein involvement or not, or like in this, there is mass in the pancreatic head.
I will
Yes, sir.
slowly run it through. I will take it back. I'm not sure if you are able to see my screen exactly the way I am scrolling it. Can you make out the pancreatic ductal dilatation
Yes, sir. Yes.
anterior to the portal vein?
Yes, sir.
And then the mass, which is starting at this location.
Yes, sir.
We'll pause it here.
Yes, sir.
If you can describe and what to see in this type of a mass, if you can say, and Dr. Chandrakant as well.
Sir, it's a pancreatic head mass. In this image, it is abutting the portal vein, sir.
Amit, an accurate description. It's a pretty decent sized mass, but I just want to go back and ask a question. When Dr. Bandari started rolling the scan, how would you know within the first few clicks that the scan was done well and it's a good quality CT?
Sir, in portal venous phase, if we can see that artery as well as the portal vein both are enhancing equally, as well as the cuts, I can see exactly the origin of the vessel, sir, and I can trace exactly the division of SMA also, sir. In this, I can make out that the pancreatic mass as well as the vessels, there is a plane I can appreciate, sir. So the cut of the slices are adequately taken, sir.
Yeah, no, you're right. Dr. Bandari, can I request you to go to the arterial phase, if you don't mind?
Sure.
So what you said is correct, Dr. Amit, but I usually, right here in this phase itself, I usually tell trainees, if what you see in the aorta is as dense as the rib, then that's a well done CT. That means there was a good amount of contrast given. And it's not just a good amount of contrast, that it was timed well. So if in the early slices of the arterial phase, the contrast is not as bright as the rib, then you know, maybe enough wasn't given or wasn't timed well. But what you said is also correct.
Dr. Ramakrishna.
Yeah, thank you. So I have one question to Dr. Amit and one to Dr. Nivedita. Nivedita, given a choice, would you have done the CP before the stent was placed, or do you just don't mind doing the CP?
So would have preferred to get it done prior to the stenting, sir, because they have already done our MRCP in this, and post stenting we have got a CT triple phase here, and I would have preferred it to be done prior to the CBD stenting, sir.
Any reason why you would?
One, I'm not sure, sir.
Amit, would you be able to?
Yes, sir. Sir, in case of stenting during the ERCP, there can be inflammation, and when we cut the lesion and put the stent inside, so the pancreatic tissue inflammation will lead to false reading in case of CECT triple phase pancreatic protocols.
It's true, and besides that, the stent itself can cause some artifacts, especially if you are the tumor, like you said, is abutting. Is this too close to the stent? You might misinterpret actual finding of the disease. The other question I would want to ask you, Dr. Bandari, if you can just go to the venous phase again. You had mentioned that the tumor is abutting the portal vein. Can you be a little bit more specific regarding your finding?
Yes, sir. Sir, tumor is uh, around the circumference of the portal vein just at the confluence of SMV and splenic vein. In this scan, it is looking like less than 180-degree contact with the portal vein, sir. And intact fat plane can be seen in this image, sir.
Yes, correct. So it's not enough if you just say the degree of contact of the tumor with the vessel. You also need to note if there is any contour abnormality or vessels. Please proceed.
Hey,
So a small point, as you correctly mentioned, Amit, that there is a clear fat plane between the vein and the tumor. So once that happens, it is not necessarily a contact with a vein. Contact is when you do not see a fat plane, and that's when you need to, of course, it is very close to the vein because pancreatic tumor will always be close to vessels. But if you see a fat plane, it's a good thing.
so on the issue of stenting, Dr. Nivedita, you send this patient to your gastroenterology colleague, and he or she calls you saying they're planning to place a stent, and you want a plastic stent or a metal stent. What would you suggest?
So I would prefer to put a short metallic stent, sir.
And why is that?
The plastic stent can migrate, the more chances of migration is there. And in a short metallic stent, in this case per se, it is a resectable tumor. So I would like to put a short metallic stent so that the bilirubin level can come down and we can rehabilitate the patient and take her or him for the surgery.
Yeah, now you're correct in many ways. Now, as you know, historically, we only place plastic stents because someone said about the reaction. The metal stent elicits a significantly more amount of reaction and fibrosis. Now, if you already have the scan and you know it's resectable like this, individual institutions do it differently, but others can chime in. A plastic stent is just as good because the longevity of a plastic stent varies to about 3 to 4 months. They can be passed, you're right. They can get blocked, you're right. They can get infected. But in a resectable patient where the purpose of the stent is just to reduce jaundice, I think a plastic stent would be acceptable. What do the other experts think?
I totally second that, Dr. Chandra.
Yeah, I also would agree with. So Dr. Nivedita, the point that I think he's trying to make is if your intention is just to bring down the bilirubin and operate as soon as the bilirubin comes down.
Yeah, I think Dr. Ari is right. I think in the US, the gastroenterologists are favoring the short metal just because of the complication rate, but that highlights the need for good communication, knowledge of your resources, how long are the operative of wait times to waiting, and then gets into the sequencing of treatment, which one you're going to do. And then just to jump back to, Dr. Ari mentioned something, said resectable. And so we're trying to, one of the goals of looking at the scan is classifying the patient, is the patient resectable, unresectable? And then between the other categories, localized, locally advanced, and advanced. And then that rolls into treatment sequences. So I don't know, would Amit like to classify the patient resectable, unresectable, and then localized or locally advanced, and then anything else he's looking for as we begin eventually transition into sequencing of treatment decisions.
And Dr. Nivedita, you're completely correct. If this is a BRPC or LAPC, the choice is going to be a metal stent. That I don't think is in question.
Okay. So this is what we have already discussed. The lesion is there, hypoenhancing head area, both ducts dilated, the vasculature is free. The other important point which should be mentioned when we read the CT is if the vasculature conventional or variable, because we know that there could be aberrant vessels, especially when it comes to the right hepatic artery, or even the variations in the common cilio-mesenteric trunk can be there. So that also note has to be made, especially when we are thinking from surgical standpoint later on. So this is what the imaging showed. We follow the patients at, okay, maybe this can be the next question to Amit, that how would you follow this patient, a bilirubin at baseline of 16.5? How do you expect the bilirubin to go down, and how do you keep such patient in follow-up after you have performed the stent, and what would you look for in this time period?
Sir, just after post-stenting, we will expect some component of pancreatitis as well as transient elevation of TLC as in this patient because of immediate stenting. In that case, we will repeat LFT every week to see LFT as well as CBC to see what is the trend. Is our stent properly working, or is there any blockage due to sludge or anything like that? So we need to see the trend of the LFT, like bilirubin is continuously decreasing, AST, ALT improving or not. And similarly, we need to follow the TLC because sometimes continuously rising TLC can show us more towards the trend of cholangitis setting in because of the blockage of the stent, sir. Every week, we will like to repeat the CBC as well as LFT, sir.
So every week. Is there any rate of fall of bilirubin that is defined, which you would take it as a standard in terms of assessment of an early stent block?
Sir,
thoughts on
if it is not falling by half in a week, I would take it as partial blockage in the stent, sir.
True. So the rate of fall, as you mentioned, was in line with what we expected. Dr. Chandrakant, please.
Amit, so this patient started off with the bilirubin of 16.
Yes.
I know each institution has different practice patterns. So what is the goal you're looking for? Normalization of bilirubin, or what percentage drop? How are you going to decide, oh, this is good, now I'm going to operate?
Sir, in this profile, we will follow the bilirubin as well as AST, ALT. We would like to see over trend of 3 to 4 weeks. Generally, we wait for 4 weeks before taking again the patient for operative intervention. We generally not tend to see the normal bilirubin level. Even 4 or 5 will work for us because it is common observation that after 4 or 5 weeks, bilirubin gets static at a range, sir. It doesn't go below that, sir.
Yeah, you're absolutely right. You don't need to aim for normal. But the reason I asked that question is you could have a 70-year-old with a bilirubin of 11 whose performance status is bad compared to a 62-year-old with a bilirubin of 15 whose performance status is good. So I think in addition to looking at this objective number and how it changes, it has to be correlated with the patient's performance status.
Yes.
Okay, so week 1 followed by week 2, which showed a steady decline with an improving patient's general health. We are at about 4 weeks after stenting. It hasn't normalized, but it has come down to 2.2, the bilirubin level. Rest of the blood parameters are good. At this stage, tumor markers are performed, which is CEA and CA 19.9. We did not discuss about this before. This has been specifically done at the end of 3 or 4 weeks, the tumor marker levels. Would you have done it before, or you are happy at 4 weeks itself, the tumor markers? And they are essentially within, the CEA is normal, but the CA 19.9 is elevated 187.
Sir,
Nivedita.
So in an obstructed system, the CA99 per se can be increased. So if we have done it earlier, even after stenting, we'll have to reassess the tumor markers. So here, the prior CA99 was 786. And after the 4 weeks of stenting, it has come down. So this would be taken as the baseline because the obstruction has been relieved, and after stenting, the CA99 value will be taken as a baseline. So.
Okay, so at this state, we have a tumor which is resectable. On the CT scan, the tumor markers are elevated, but not very high, 187. What would be the next step? Any tissue diagnosis required?
Since it is a resectable tumor, tissue diagnosis is not mandatory, sir. As per the imaging and with the tumor markers and with the patient's history, most probably it is pancreatic duct carcinoma. So tissue diagnosis is not mandatory in a case of a resectable tumor, sir.
Dr. Ramakrishna.
Dr. Nivedita, in what situation would you consider doing a tissue biopsy?
If it is a borderline resectable tumors, or if you're planning to give a neoadjuvant therapy, we can do a tissue diagnosis, sir. And since if we have stented the patient, if we are seeing a lesion per se, we can, since we have intervened with stenting, in that case, if we are able to do a tissue diagnosis, we can do a tissue diagnosis. But in a resectable case per se, tissue diagnosis is not mandatory, sir.
And if you were forced to do a tissue diagnosis, what would be your approach to? Would you plan for a CT guided biopsy, or would you try something?
EUS FNA will be preferred, sir.
Are you happy with the FNA, or ask for an EUS?
EUS biopsy, preferably.
Please carry on.
Dr. David, please.
Dr. Bandar, you mentioned the level of the CA19-9. So, and you said it was characterized as lower or in a lower range. What range would cause you to change, your treatment sequences or consider neoadjuvant therapy and then get a biopsy? What number is it? 1,000? Is it 500? What numbers?
As per the guidelines, of course, anything which is more than 500 becomes a borderline resectable as per the CA19-9 definition. But at our unit, we have a policy of 300 of CA19-9. Above that, we would consider, even in presence of a resectable disease radiologically, we would err on a side of offering neoadjuvant first. Maybe that is also a part of discussion today, that in a resectable tumor, do we do a surgery first, or do we do a neoadjuvant approach first?
Amit, can you answer that question?
Any evidence, Amit?
Yes, sir. Recently concluded trial from NORPAC trial, sir, shown that in upfront resectable patient, it's better to operate biologically resectable. If clinical resectability is confirmed, sir, based on conditional biological as well as anatomical resectability, we should upfront operate the patient rather than giving neoadjuvant first, sir, according to NORPAC trials.
Why is that so? The reason being, you're right that the NORPAC results suggest that maybe a resectable tumor should be operated upfront. In a way, that is a negative trial for neoadjuvant therapy for PDAC. But what is the reason for that negative result in that particular trial? Are you aware of that? Basically, the toxicity was higher. The chemotherapy that we have is more toxic, so the dropout rates related to the toxicity are high. So if we have a well-tolerated neoadjuvant therapy, That is what we are all looking at. If that comes in, maybe the future management might change. But yes, as of now, we are right to operate such patient. Is everybody agrees? Does everybody agree to that? From the panel as well, that we operate this patient?
Yes. Again, institutions do it differently, but there's
True.
more and more pressure, or whatever you want to call it, towards offering neoadjuvant therapy to everyone with pancreas cancer, because despite, when we all started training, the 5-year survival was in dismal low single digits. Now it's 11% to 12%, but the one thing we all can agree is most people still think that at any stage it's still a systemic disease. And that's why I tend to see more and more people beyond just medical oncologists saying at any stage we should give upfront therapy, although I don't personally agree with that. Dr. Ventra?
I agree with Dr. Ari. In the US, the rates have slowly crept up, for the last 10, 15 years, 20%, 30% of localized patients. It's finally past 50%. So maybe it's 60% of patients in the US for localized disease get neoadjuvant therapy first. But it's the things that were mentioned today. Dr. Ari noted the size of the tumor, looking for the end stage. How's the adenopathy on the scan, and then the height of the biomarker. And so all these things are painting a picture. And then along with the performance status, we mentioned that, the 60-year-old versus the 80-year-old. And then the resources at your center. If it takes 6 weeks, 3 weeks to see an oncologist, 2 weeks to get a port, 2 weeks to start chemotherapy, all that factors into time to treatment. So it just depends a little bit on why we have some of that variability. But in this case, with a localized tumor in a fit patient, I agree with the assessment.
The other thing just to mention is for tumors, let's say breast cancer, colorectal cancer, there was evidence of effective adjuvant treatments before we shifted to neoadjuvant. Whereas in pancreas cancer, there isn't effective adjuvant therapy even now. Yes, there's FOLFOX, FOLFIRINOX, and nab-paclitaxel, but nowhere close to the effectiveness of other organs. So I think if we see more effective adjuvant therapy, I think the debate will reduce about giving neoadjuvant therapy, because I still think, all those patients that we said, a fantastic Whipple, they had liver mets 3 months post-op, they had systemic disease. We just didn't know about it.
But Dr. Bhandari raises an excellent point about toxicity. Think of it in a way of toxicity with surgery. Some will quote that 30% won't go on because some complication won't go on to adjuvant therapy. That may be the difference in our Alliance trial that just accrued and is still maturing. But there is toxicity with chemotherapy, and then those folks may not get surgery, and so that, which may be the most impactful treatment for a localized tumor, but it's hard to know.
Absolutely. So this patient did undergo a surgery. It was a pylorus preserving pancreatoduodenectomy. Any technical questions for the students? Dr. Chandrakant?
Dr. Nivedita, Dr. Bhandari mentioned pylorus preserving, and then you have the classic Whipple. Any reason to do one or the other?
So there is no like pylorus preserving pancreaticoduodenectomies. They say that the delayed gastric emptying, the complication is comparatively less, but there is no proven trial or any evidence to say that one is the pylorus preserving or the classical Whipples is superior to one another.
Others can chime in again. In my training, I could see the trend going from classic Whipple to pylorus preserving, that till when I was leaving the institution where I trained, 90% were pylorus preserving. And the general observation is that you said the nutritional outcomes are better. And if there's any delayed gastric emptying, some of the drugs that you can give, such as erythromycin, they only work when you have an intact pylorus. So I think I'd be keen to hear what the other experts think, but in our institution, if you can preserve the pylorus, that's what we do. But for resection's sake, if you cannot, then we want to sleep over it.
Yeah, I was trying to remember the utilization rates I've seen from the U.S. You know, the National Cancer Database has the probably most patients in it. They say 70% of the patients, and I thought it was maybe 2/3 to 1/3. You know, pylorus preserving to standard. So there is still variability, and I would say the knock on the pylorus preserving, it is, we think it's more physiologic or perhaps better for nutrition, but it's perhaps slightly higher rates of delayed gastric emptying. And so if you can get them through that initial month or a couple weeks, then you might see the benefit. But initially, they have seen some higher rates, but it's really difficult to study.
I would say that, yes, I agree that maybe there could be slightly higher rates of delayed gastric emptying with pylorus preservation, but the rates of biliary reflux gastritis are much, much lower. And what we also practice is doing a bronze anastomosis, jejunal anastomosis, which probably also reduces the delayed gastric emptying rates as per few reports. But to be honest, I think whenever feasible, pylorus preservation is our strategy as well. And in terms of the resectability, how do we ensure R0 resection in a case of pancreatic head cancer? Dr. Amit?
Yes, sir. Sir, to decide the upfront resectability, first we want to see the SMA.
For example, let me be clear. I mean, in this particular case, when you saw the lesion is there in the head, which is close to the portal vein, this is an area which is difficult always, pancreatic head. How do you ensure? Do we have any specified surgical maneuvers or approaches that we ensure that we get an R0 resection during the uncinate dissection?
We will like to do the artery first approach, sir. We will approach it from the posterior approach, sir. Uplift and doing a wide cockerization, sir, and clearing the area between the superior mesenteric artery as well as celiac axis as well as portal vein, sir. And after doing that, we see that SMA is not involved. We can start dividing the perivascular tissue over the SMA and taking out all the tissue from the uncinate margin that can be positive in the post-operatives histopaths.
Dr. Amit, if I may ask you, what would you call R0 resection? How would you define an R0 resection?
Sir, R0 resection is in terms of uncinate, sir, it should be at least 1 mm margin, sir.
What other margins would you look?
I would like to see the margins in most important in this case is uncinate margin, sir. I mean the SMA margin, sir. Then the CBD margin, sir. Our enteric margin, sir. And then I would like to see the posterior margin of the pancreas posterior border also, sir. SMV groove margin, sir. With the SMV, we will dissect around it. And then anteriorly, as such, there is no margin, sir, on the anterior side of the pancreas, sir. It's a free border, anterior border, sir.
What margin would you want to give when you transect the pancreas?
Pancreatic neck margins.
Yes. What would be an acceptable margin in that?
5 mm, sir.
So, Dr. Amit,
Yes.
a nice description of all the margins, and we will come very far from 20, 30 years ago where we did margins so arbitrarily that one institution's data could not be compared to another. Now there's a significant standardization. So I'm going to posit two scenarios. So you send this for margins and the pathologist comes back and says, the neck margin is positive. What are you going to do?
Intraoperatively, sir.
Yes.
We would like to take further margin on the neck side, sir.
Okay, that's a 50% correct answer. You take another slice of pancreas and it comes back positive again. What would you do? So there are two schools of thought here. One school says, if those margins keep coming back positive, the disease is so bad, you could do any operation. It's a reflection of bad biology and that you should stop. Whereas there are some that say, I'm going to chase this till I eliminate every panic. And if it means doing a total pancreatectomy, I would do that. But in general, depending on the institution where you are, you have your own practices. If your neck margin is positive, that's where you have the room to take additional resection. Usually, if the uncinate margin is positive, there's not much room to go resect. It is what it is. I'd like to hear what other experts think.
Well, I'll chime in. I agree with Dr. Ari. I agree with the biology, and that was one of the things that consideration begins when you're evaluating the CT scan. As you follow the pancreatic duct down, you get a sense of just not only the contour of the vein, but the contour of the pancreatic duct. So this neck looked widely free. So I'd be shocked if this one had a neck margin problem. And then, like Ahmed said, the issue is going to be the uncinate margin. But I agree with Dr. R. I mean, I don't think total pancreatectomy is perhaps, a death sentence. Maybe it was 20 years ago, but it is difficult to manage, particularly if you need more systemic therapy. So if in that situation where you're trying to prioritize getting the systemic therapy, a total pancreatectomy may not be the best scenario for the majority of patients.
Manish, I think we need to move on to the next.
So I think we have about 15 minutes left. So the surgery was R0. The standard reconstruction was performed in the form of a ductal mucosa anastomosis, pancreaticojejunostomy. The pathology report mentions the recovery was good. The pathology report mentions a head pancreas, poorly differentiated adenocarcinoma, lymphovascular invasion and perineural invasion was present in this case. 5 lymph nodes were positive. Margins, as I mentioned, free. It's a T2N0. What next? Quickly, because we need to move to the next case also. Nivedita?
Sir, adjuvant chemotherapy has to be given.
No radiation.
So there is no the trials per se haven't given any the radiation doesn't improve the disease-free survival or progression survival or overall survival. Adjuvant chemo.
Yeah. So
what regimen do you use?
Yeah, which regimen?
Modified FOLFIRINOX is the current.
How many cycles?
8 cycles, sir.
Okay, so 12 cycles, 8 to 12 cycles. Not every patient will be able to finish 12 cycles, but the recommendation would be to complete 8 to 12 cycles of modified FOLFIRINOX. That's what this patient received and is on follow-up. Going to the second case, we will skip. Yes, Dr.
A quick comment before we leave that case. Those were beautiful operative pictures, flawless dissection. Sadly, it's a common scenario, poorly differentiated tumor, node positive, all too common these days. But the nodal count was spectacular, 19 nodes evaluated. That's, high level pathology.
And just a quick point as well, which we didn't know 15, 20 years ago. presence of lymphovascular invasion and perineural invasion are significantly negative prognostic factors. So while all margins are negative and the lymph node ratio is not that high, you should view this pathology as not good. Almost 3 centimeters, poorly differentiated, both LVI and PNI. So I think in the interest of time, we'll move on. Yeah.
True, I agree. And I would also want to highlight this case as well because it would make the point even more clear what Dr. Chandrakant was mentioning. You saw the previous patient CT scan. The lesion was larger, but there was clear fat plane. There was no lymph nodes. But you see the report of lymphovascular invasion and nodal positivity. This is a lady from northern part of India who presents again with obstructive jaundice. No significant family history. The general examination, apart from icterus, no other problems. The starting bilirubin level was 5. Rest of the blood parameters more or less similar to the previous case. You see that the tumor markers were within normal range, even at presentation, at even with the obstructive jaundice. Patient underwent a stent placement. Now this sequence is little, but I am anyway going to present the CT scan and the what has been done to the patient before. A plastic stent was placed, an EUS was performed, a biopsy was obtained, and of course this was after the CT scan and the PET scan. And this is the CT image, which is pre-treatment image. This is a borderline resectable case. Nivedita, can you quickly read out this image? Have a look at the image and then you can describe.
So there is a ill-defined hypoenhancing lesion in the head of the pancreas and
Back again
head
slowly.
of the pancreas.
Yeah.
Head and body also extending to the body of the pancreas, maybe around 3 into 3 centimeter. There is a stent in situ, and it is also encasing the portal vein and the SFV and CBD, as well as the main pancreatic duct is also dilated.
Any comment on the artery, superior mesenteric artery?
Artery seems to be free, sir.
So you said that the vein is involved.
Portal vein
What location is the vein involved?
at the confluence where the portal vein as well as the SMV.
How the confluence gets formed?
SMV and the SMV joins the splenic vein, and SMV joins the and becomes a portal
At
vein.
the splenoportal
Portal
confluence, at this level where you see the splenic vein joining, and that's where the contour changes and the caliber changes. So the involvement starts there. Anything else that you want to know in terms of the vein involvement? When you read a CT and you see that there is a vein involvement, what are the details that you want to know?
Any contour variability is there, or how much more than 180-degree lessen the contact, as well as if there is any occlusion, and how, if it is a short length or a long length of occlusion, segment occlusion. And
why would you want to know the length of that is occluded?
So for the reconstruction, for planning the reconstruction.
Is there anything else that you would want to know to plan reconstruction? What are you basically trying to look at the borderline pancreatic cancer? Do you think this patient can have a surgery and a portal vein resection?
So we can give the neoadjuvant chemotherapy and then reassess the patient and if the and downstage the disease and then plan for surgery.
So before giving neoadjuvant treatment, why can't you operate on this patient? Is there anything that tells you this is unresectable tumor? You could operate on this patient, right? If total the spinoportal confluence is the only thing that is hindering you, you could do a vascular resection and reconstruct. Is there any reason that you wouldn't want to? Why would you want to give neoadjuvant treatment for borderline resection?
Is there any evidence?
So it actually downstages the disease and we'll have a better.
You want to get a negative margin, right? That's the basic principle of any oncological surgery. You could still operate on this patient, but the chances that you end up with R1 margin is pretty. That is why you would probably want to give adjuvant treatment. The other reason is borderline resectable, also a chance of focal systemic disease. Tackle that. These are the two reasons why you prefer giving.
Nivedita, you're right about what you mentioned. I think to be very specific on the CT scan when there's venous involvement, you alluded to that you want to make sure that there are landing zones if you have to do a reconstruction. But I want to go one slide back, and Dr. Amit,
Yes.
this is a 41-year-old female patient. I know in India, the onset of cancer tends to be a decade younger. Let's say breast cancer in the West is 50s. In India, it's 40s, but it's still young. When you see a 41-year-old with what might be pancreas cancer, what is going on in your mind?
Sir, first, based on this history and these findings, I would like to rule out autoimmune pancreatitis, sir, in this patient, as well as after ruling out that possibility, I would also rule out the family history and any genetic testing I can do upfront on the biopsy to see if I can get targetable immunotherapy or something like that, sir.
Yeah, you're absolutely right. 41 is very young. The youngest I operated was at 29, but those are all anecdotes. So you're absolutely right. You want to look at the family history, genetic predisposition, syndromes, hereditary breast, ovarian cancer, and all that. Yeah, please move on, Dr. Bandari. I think we only have a few more minutes.
Yes.
No, I agree though, but you could go right to surgery. There was some contour change, but this tumor is actually the smaller. And then the only other comment I would add about why neoadjuvant, the risks do go up with a vein patch, vein resection. And so again, we know that getting all the treatments is the best thing. So you're more likely to do that with a higher risk surgery, doing some upfront.
Neoadjuvant therapy is what everyone said. Yes. Two options, as we know, we have FOLFIRINOX or gem-nab-paclitaxel. How do we choose broadly, Amit, between the two?
Sir, based on the ECOG performance of the patient, if it's a good ECOG, we would like to give modified FOLFIRINOX. If not, then we would like to give gem with nab-pacli. But recent trials suggest that gem plus nab-paclitaxel is kind of non-inferior in comparison to FOLFIRINOX, modified FOLFIRINOX.
Yes, kind of. You are right about that. This patient received gem with nab-paclitaxel because there was some issue with stent exchange, cholangitis, and reduced performance status. So a gem nab-paclitaxel was done, and she tolerated that dose well. Dr. Chandrakant, you want to mention something?
Yeah, quickly, there's so much data variation, but in general, most of the data is for the FOLFIRINOX or modified FOLFIRINOX. So that's why you're right, Amit. If the patient can tolerate it, most of us would go for modified FOLFIRINOX. Dr. Bentram?
I think that's right for a younger patient, at least in the US, although I see more of this regimen used in Germany. So they've been studying it a lot. You know, there's what was that trial? The Neonax trial. They did this gem plus nab-paclitaxel. They did 2 cycles before, 4 after. So I know they're using it more there.
Any quick comment from the experts on radiation in neoadjuvant approach?
I think on this side of the pond, radiation is given more than the other side of the pond, but even that is changing now. We're becoming more European than we were about 10 years ago. Dr. Bentram?
Yeah, I agree with Dr. Ari. And then perhaps more with locally, unresectable patients will use it more. But I agree, we're using less, more for just margin positive or unresectable cases, trying to convert to resectable.
So, Dr. Nivedita, this is the post therapy response scan. The patient had a hemangioma in segment 6 of the liver that was noted before as well. And this is the venous phase post chemotherapy. If you want, I can run it back again.
Almost stable hypoenhancing lesion is still present in the head and the head of the pancreas, the stent in situ, and MPT.
Dr. Nivedita, do you think this is a failure of neoadjuvant treatment? The tumor has not responded. Do you think this is a failure of neoadjuvant treatment, or would you want to do something more to characterize the response?
Since the tumor is stable, Dr. Ramakrishnan is asking, is this failed neoadjuvant therapy?
I'm not.
How much can you rely on just imaging for assessing response following neoadjuvant treatment? Dr. Amit?
Sir, especially in pancreatic malignancies, because of severe desmoplastic reaction, even after chemotherapy, even there is response biologically, the disease will look stable, as this is kind of exception for the RECIST criteria. Especially in this patient, as CA99 was already normal, sir. So even we can't follow based on that if it was increased before 900,000. And so we can see biologically it is responding or not, but in this case, CA99 was also normal, sir. So
Is
based
there
on
anything else that you could elicit from the patient that might give you a hint?
yes, sir. Symptoms, improvement in patient general physical conditions like reversal of loss of appetite, weight gain, such factors will indicate that biologically disease is responding, sir, to
You're
our.
absolutely right. Not just rely on your imaging. If the CA99 was elevated upfront, see how much it has reduced. Also see the how the performance status, that there's been any weight gain. These are things that would give you a clue how the tumor is responded to.
I think we'll only have 1 minute or so, but I do want to highlight what Dr. Amit mentioned. Years ago, response was based only on size, physical size. Then we went to morphologic criteria. Now in the era of immunotherapy, there's immunotherapy-related criteria. So you're absolutely right. Size does make a difference, but there's more criteria than just the physical size.
Okay. So surgery, this patient underwent surgery at this stage. Would the panelist, would the experts also agree with that, or would the experts want more therapy to be done with a stable disease on radiology and a normal CA19-9 levels? 4 cycles.
I would agree with you, your decision.
Okay,
I
so
think
The surgery
is the
is,
way to go.
yes, the surgery is type 3 PVR is what is mentioned. Nivedita, can you?
Yes, sir. So there are 4 types of portovenous reconstruction.
Resections rather.
So
The types of portal
yes, sir.
vein resections.
The first one is you will the partial resection of the vein with the primary venography is type 1, and type 2 is when there is a partial resection with the patch closure, and type 3 is there is segmental resection but with primary venovenous anastomosis, and if type 4 is there is segmental resection of the portal vein and then you do a contour interposed contour reconstruction, sir. So here it is mentioned as type 3 with the primary segmental resection of the portal vein with venovenous anastomosis, sir.
Yes, so there are many technical things to be discussed also in a portal vein resection, but I think for the want of time, we cannot go into the details of them. As it was noted in the CT, it was at the splenoportal confluence, but actually the involvement was slightly lower into the superior mesenteric vein. As you can notice here at the lower clamps, you see that there are 2 veins, the superior mesenteric vein and the first jejunal vein, and the splenic vein was possible to be saved. And that's how it was a type 3 end-to-end reconstruction performed. And the right picture, as you see here, that the splenic vein being preserved and the anastomosis being performed. Patient did recover well. This is the pathology report. And this is what I wanted to mention. We have a borderline resectable tumor at presentation, but see the pathology is, it is T2 node negative. LVIPNI was still present though, but the nodes were negative as compared to a patient with a resectable disease with the pathology which it was before. So at this stage, what therapy adjuvant?
We'll complete, she has already received 4 cycles prior to the surgery, sir. So we will complete the 4 more cycles of gem-nab-paclitaxel.
Just quickly, before we go off, in patients that receive neoadjuvant therapy, the degree of response or the degree of residual tumor is a very good prognostic factor. So there are many grading systems. So if you take esophagectomy, neoadjuvant therapy, and a complete pathologic response, the 5-year survival goes from 20 to almost 50 to 60%. So in someone that has neoadjuvant therapy, you've added a new prognostic factor that can be measured.
Right, great. So thank you so much, our faculty today and our examinees. I wish we could continue with this discussion, but for want of time, I think we'll move on to the next segment of this webinar, which will be the expert talk. The first talk is going to be on the current approaches and the strategies in locally advanced pancreatic cancer, and it will be delivered by Dr. Ramakrishnan. As he loads his screen and starts, I request our faculty to kindly go through the Q&A and the chat and answer some of the questions that our live participants have posed. Over to you, Dr. Ramakrishnan.
Good evening and welcome to this joint IASO-SSO Masterclass series on pancreatic cancers. I am Dr. Ramakrishnan and I will be talking to you today on the current management of locally advanced pancreatic cancer. Locally advanced pancreatic cancers constitute around 30 to 40% of all pancreatic cancers that we see. They are historically associated with poor survival, with a median overall survival of just about 9 months without any conversion or aggressive local therapy. Now, there are many different definitions of locally advanced pancreatic cancer, but essentially it is a non-metastasized pancreatic cancer in which upfront resection is considered not beneficial due to extensive vascular involvement and the consequent high chance of a non-radical resection. Basically, all these guidelines converge in defining locally advanced pancreatic cancer as a cancer in which there is more than 180 degrees engagement of the SMA or the celiac axis, or unreconstructable involvement of the SMV portal vein. There has been a shift in the traditional staging of localized pancreatic cancers from the anatomy to the biology. It was proposed by Katz in 2008 that the staging should be shifted to something called the ABC, that is anatomical, biological, and conditional aspects of the staging, so that it is not just the anatomy that is considered while defining pancreatic cancers, but also biology of the tumor. For example, a high CA99 level, or the condition of the patient, logical reserve of the patient for EPOG status. So we now know that it is not just the anatomy that controls the staging, but also the biology. The Transatlantic Pancreatic Surgery Consortium has come up with a scoring system to stage pancreatic cancers based on the ABC terminology, in which locally advanced pancreatic cancer is automatically assigned 2 points. Similarly, the other risk factors like a high CA99 or a WHO performance status more than 1 are also assigned different points. So totally you have a score of 0. And this score has been shown to predict the overall outcomes of treatment in pancreatic cancers, with a score of 0 having a median survival of nearly 50 months, compared to just 15 months in the score with 4. So what are the aims of managing locally advanced pancreatic cancer? The primary aim is systemic control, stabilize the primary tumor, test the tumor biology before a high-risk surgery, and control the occult micrometastasis. Secondary aim is conversion surgery, where you downstage or devitalize the tumor at the vascular interface, thus transitioning the patient from a palliative to a curative intent. So it is important to keep the patient at the center of all your treatment decisions, have a proper goals of care discussion with the patient and the caregiver, so that whatever treatment you offer is aligned with the patient's preferences and patients. You have to balance escalation of treatment to the symptomatic relief and the ability to tolerate the treatment, prioritizing the quality of life and maximizing the time at home. Since many patients with LAPC are usually above 60 or 70 years, a thorough geriatric evaluation is required to assess the frailty and the logical reserve before deciding on escalating or de-escalating. Global guidelines for LAPC converge in the sense that induction systemic therapy is recommended by all the guidelines. Multi-agent induction therapy is the first step of induction therapy in all the guidelines. However, they diverge in the recommendations regarding the duration of the chemotherapy and specific indications for radiotherapy. Backbone for induction is, as I told you, chemotherapy. There are different options of chemotherapy available. You have the M-FOLFIRINOX regime, the gemcitabine nab-paclitaxel regimen, and also based on the BRCA mutations. The patient with a BRCA mutation, a gemcitabine cisplatin combination is preferred because it is more sensitive. Now, FOLFIRINOX is currently the first choice for induction therapy in a patient who is fit enough to receive it. There was recently a large study published by the Transatlantic Pancreatic Surgery Consortium, which showed that following FOLFIRINOX, there was nearly 18% of the patients could proceed to resection after 7 cycles of chemotherapy, and nearly 55% of these patients actually underwent surgery had an R0 resection. 18-month overall survival was, the median overall survival in these patients was 18 months, the entire population, but it went up to 38 months if the patients had a surgery. The other drug is a combination of gemcitabine and nab-paclitaxel. The LAPACT trial was a phase 2 trial in which induction was used with gemcitabine, nab-paclitaxel, followed by either continuing the same or surgery or chemoradiation. This trial showed that this combination of gemcitabine and nab-paclitaxel had a disease control rate of almost 78%, and nearly 16% of these patients successfully underwent surgery. Now, there are only 2 small randomized trials which are looking at different systemic agents in LAPC for induction chemotherapy. One was the Prodigy 29 or the NeoPan trial, which compared FOLFIRINOX with gemcitabine. Although it showed statistically significant but only a modest improvement in the median progression-free survival, there was no significant difference. The other trial was the JCOG 1407 trial, which is a Japanese phase 2 trial which compared FOLFIRINOX and nab-paclitaxel. This trial did not show any overall survival advantage of one combination over the other. However, gem-nab-paclitaxel had a better response rate and a more favorable toxicity. There's also been an attempt to switch chemotherapy in order to improve the resection rates and overall outcome. The NeoLab trial looked at induction with gemcitabine nab-paclitaxel and then randomizing the patients to either continuing the same regimen or to switching to sequential FOLFIRINOX. However, this trial did not show any significant difference in the exploration rate or the surgical conversion rates or the adverse events between these 2 regimens. The ideal duration of neoadjuvant treatment varies, but it is preferable to expose the patient to systemic chemotherapy for at least 4 to 6 months, either as total neoadjuvant or as a perioperative chemotherapy. But in practice, instead of following rigid timelines, it is always better to depend on not just the radiological response, but also the CA19-9 kinetics and the patient's tolerability. So it is advisable to keep assessing the patient every 2 months with pancreatic protocol CT scan and CA19-9. Now, the role of radiotherapy in LAPC is less defined. LAP-07 trial actually looked at randomizing patients to gemcitabine chemotherapy or chemoradiotherapy after disease control, after disease stabilization with 4 months of gemcitabine induction. However, this trial failed to show any advantage in median overall survival when chemoradiotherapy was added to induction therapy. There was a statistically insignificant improvement in the local control rate when chemoradiation was. So routine use of chemoradiotherapy is probably not recommended for all patients with LAPC. It, however, may be beneficial for selected patients with local program. The more recently published CONCOS 007 trial evaluated the addition of chemoradiation to an induction chemotherapy of dealer's choice, either gemcitabine or FOLFIRINOX. This trial showed that induction therapy enabled at least a third of initially unresectable tumors to be brought to the table. In the entire patient population, the overall R0 resection rate was not very different between chemoradiation and chemotherapy alone, nor was the median overall survival. However, in the cohort of patients who underwent surgery, the R0 resection rate was around 70% in patients who received chemoradiation versus 50% in patients who only chemo. There was almost doubling of the 5-year overall survival. However, this was not statistical. But there was a statistically significant reduction in the overall locoregional recurrence when chemoradiation was added to induction chemotherapy. So radiation can be used as a tool for optimizing local clearance, but not as a substitute for control. But beyond overall survival, addition of radiation may help in other ways, might increase the probability of achieving R0 sections, may provide superior locoregional control of the primary tumor. It can help in symptom palliation by delaying the onset of symptoms, and it also improves the quality of life, and it helps to de-escalate systemic chemotherapy, thereby enabling the patient to spend more time at home. Now, the key to improve outcomes in locally advanced pancreatic cancer is to convert these tumors into a surgically resectable tumor. After neoadjuvant therapy, there has been a almost doubling of the survival time in patients who underwent surgical resection when compared to those patients who did not undergo surgical resection. The 5-year overall survival was almost threefold increase in patients who undergo. So achieving a margin negative resection is the most important intervention to improve long-term survival in locally advanced pancreatic. So in every 100 patients who undergo treatment induction therapy for locally advanced pancreatic cancer, roughly a quarter to a third of these patients undergo surgical exploration. However, nearly 30% of this group of patients who come to the table have a negative laparotomy in the sense that they do not proceed to section. The remaining 70% undergo surgical resection. So from the initial 100 patients, roughly around 18% of the patients ultimately undergo surgical resection. So how do you choose patients for surgery? It is known that imaging is not a very good way to select patients for surgery because it does not really differentiate between viable tumor and fibrotic tissue. Even though the tumor might have responded, it may not reflect on the imaging. However, a more important aspect of tumor response evaluation is using the biomarker CA19-9. This is thought to be even superior to imaging for assessing the response. Generally, it is thought that a decline of more than 50% is a strong predictor of resectability and survival. If it returns to normal, then that is the best predictor of resectability. ctDNA has been emerging as a tool to help choose patients for undergoing surgery. However, use of ctDNA is still in its nascent stage. So right now, it is not used in practice for selecting patients to undergo surgery. Is there any other way in which we can choose patients who are likely to have a resection? The Johns Hopkins group has come up with a LAPC score, which is a tired anatomical classification that predicts the eventuality of surgical exploration. They divide patients into LAPC1, LAPC2, and LAPC3, depending on whether they are likely to undergo surgical resection or highly unlikely to undergo. Basically, it depends on the involvement of the artery or the vein, and based on this, the tumors are scored as LAPC 1, 2, or 3. And this has also been shown to be associated with the overall survival. Here you can see that as you go from LAPC 1 to LAPC 3, percentage of patients who undergo exploration and subsequent resection dramatically declines from nearly 50% of LAPC 1 patients who undergo resection to just about 10% of LAPC 3 patients who underwent surgical resection. Similarly, the survival also dramatically drops as you go down from LAPC 1 to LAPC. So there have been a lot of advancements in surgical techniques which have enabled number of patients with locally advanced pancreatic cancers to undergo resection. Venous resection is now no longer an absolute contraindication for surgery. It is now known that venous resection and reconstruction can be safely performed with a mortality of less than 4% and a major morbidity of less than 30% in volume cells. There are different ways in which the vein can be resected and reconstructed. I'm sure you will all know this classification of type 1 to type 4 venous involvement and this methods of venous reconstruction. I'm not going to go too much into detail about this. Similarly, the arterial involvement is also very important in dealing during surgery. There are different approaches in which you could improve the chances of resection. The artery first approach, triangle operation, the arterial divestment, or finally the arterial resection. Arterial divestment It's procedure where you peel the tumor of the adventitia of the celiac artery or the SMA. This reduces the vascular mobility and enables more tumors to be cleared. Whereas resection of the artery is associated with very high morbidity and at least when the earlier days, higher mortality. Whether it is arterial divestment or arterial resection, recent series have shown very good oncological outcomes with these procedures, with median survival time of upwards of 40 months and 5-year survival rates of varying from 33% following arterial resection to 46% following arterial divestment procedure. However, you need to be cautious that arterial resection is generally reserved for very strictly selected patients who have a favorable response to neoadjuvant induction therapy. The Rediscover guidelines that was published recently clearly states that arterial resection is indicated in patients who have a limited but reconstructible involvement of either the celiac axis or the common hepatic artery. Then it is performed in expert high volume centers in patients who demonstrate radiological and biochemical evidence of durable resistance. Generally thought to be contraindicated when there is no encasement of the superior midcentric artery or in a patient who has a very poor performance status. So if a patient is unable to undergo surgical resections, he or she could be offered other local ablative therapies. A lot of local ablative therapies have been tried, including stereotactic body radiotherapy, irreversible electroporation, using tumor treatment fields or radiofrequency ablation, etc. However, except for the tumor treating fields, none of the other ablative therapies have so far shown to improve the survival, although they might have some advantage in improving. What lies in the future? ctDNA integration with the induction chemotherapy can be probably used in dynamically monitoring for micrometastatic disease and also choosing patients who are likely to have better outcomes if they undergo surgery. Molecular subtyping using the GATA6 expression can differentiate tumors into either the classical type or the basal subtype. Classical types are relatively more sensitive to FOLFIRINOX, so you can select patients who may need a different chemotherapy regimen than FOLFIRINOX based on molecular subtype. Similarly, a lot of actionable targets are being evaluated. The NTRK fusion genes, the KRAS mutations, and also the MMR mutations. Currently, there are many ongoing trials in the landscape of locally advanced pancreatic cancers that either look at intensifying radiotherapy or optimizing systemic treatment or targeting the stroma, which is thought to be a physical barrier in pancreatic cancer using different agents like CD40 agonists or hyaluronidase. Finally, you must not forget that only around 30% of patients who undergo induction therapy actually may end up having a surgical resection even at the high volume centers. The remaining patients who remain unresectable, it's very important to maintain a good quality of life and based on their goals of care to provide them appropriate pain management and stepping down from multi-agent chemotherapy, allowing them to spend more time at home. Management of locally advanced pancreatic cancers is best done in high volume centers where you have all the inputs from the different specialties, not just the surgical specialties, but all the oncology specialties, palliative care, pathology, interventional radiology, etc. And also, it is important to integrate palliative care early on in the treatment of patients, that you can align treatment with the goals of care only. Finally, In summary, locally advanced pancreatic cancer is no longer considered universally unresectable. Primary goal of treatment, systemic therapy, followed by surgical conversion. Multi-agent induction chemotherapy is the backbone of the systemic therapy, using either FOLFIRINOX or in patients who are unable to tolerate FOLFIRINOX, combination of gemcitabine and nab-paclitaxel. Biological response, that is the kinetics of the CA19-9, outranks the static analytical imaging when determining the true surgical. R0 resection offers a very profound impact on the survival. However, it needs to be performed in centralized, high-volume, multidisciplinary centers. Thank you.
Thank you, Dr. Ramakrishnan. I think we'll take the questions which are there at the end of the other talk as well. So now I invite Dr. David Bentram for his talk on the surgical options for oligometastatic pancreatic cancer.
I'm Dave Bentram from Chicago, and first I want to take a minute to thank the SSO and Dr. Ari for setting up this great webinar. Tonight I'm going to talk about the role of surgery for stage 4 pancreatic cancer. We all know that advanced pancreatic cancer is how most patients die, and it's characterized by the spread from the primary tumor, either hematogenous spread to most commonly the liver, or the next most common is the lung, or lymphatic spread to a lymph node basin that's out of the standard resection for positive lymph nodes. Unfortunately, this is a common situation. Localized patients are well under 20% of cases, locally advanced 40%, and then advanced at another 40%. We're usually trying to disrupt this cycle in this area, but is there something else we can offer for the stage 4 patient? We know pancreatic cancer is a disease of inherited and acquired mutations that change the normal ductal epithelium to dysplastic cells, and then high-grade dysplasia, and then adenocarcinoma. But the challenge has been applying this knowledge to patient care through the years. We did this earlier report. We were trying to highlight that not all stage 1 patients undergo treatment, and their outcomes quickly join those of the stage 4 patients, and where the median survival is 8 to 12 months, and the 5-year survival is under 5%. Here was 3.2%. And then we did this report last year from the National Cancer Database, where we thought it was important for a surgical oncologist to bear in mind, what the outcomes are for the top 8 cancers, and you can see the 3-year overall survival on the y-axis, the really measurable survival for prostate and breast of around 50% 3-year survival, and then you see the disease sites where immunotherapy has made an impact, melanoma and kidney cancer, and even lung has crossed bladder cancer when there's really been not a lot of change, and unfortunately pancreas is here at the bottom through these 20 years. So it's difficult for technical maneuvers to overcome this biology. And it hasn't been that long since we've been removing the primary tumors here. Alan Whipple and his two-day pancreatic duodenectomy in 1935. And it'd be a Halstedian to think that we could sort of cut our way out of this for a stage 4 patient here, where they're removing the breast before CT scan for some advanced patients with poor outcomes. And this is not the type of patient where we should offer further surgery. You can see the extent of disease, the high volume of disease. But given that this old classic Blake Cady quote, given that biology is king, is there selection that we can use to try to find the right patients or the few patients that maybe we can offer for resection to. And so we could use colorectal cancer and spread to the liver and hepatic resection as perhaps a guide where we use clinical factors, extent of disease, and maybe a serum marker here at CEA to try to select the best patients with the lowest volume of disease that we could study or talk about offering a treatment to. And so because we want to do more than just perhaps extend their outcome survival just by having an earlier diagnosis or the classic lead time improvement, but we're trying to shift the date that they die beyond the classic dead of disease day. And so considerations for surgery in stage 4 patients, talk about the goals of surgery, where it's generally palliative and aimed at improving quality of life. Bear in mind resectability or morbidity of any sort of planned resections for lower volume disease, or when might that be considered, and then what are the palliative procedures. The usual biliary obstruction, intestinal obstructions, sure, but are in select cases, if a patient has a good response to chemotherapy, maybe one spot or low volume of disease, can we consider removing the primary tumor for oligometastatic disease? And this report came out in 2009 from Johns Hopkins. We're talking about the patterns of failure, and they had highlighted about 30% of patients die of mainly localized disease, but their definition of localized disease included patients with less than 10 liver lesions or oligometastatic disease. So, but this started to change people's thinking. And then I want to offer up a few retrospective series for high volume centers where they've been studying their outcomes. And first is a German series from Dr. Buchler's group in Heidelberg. It was about a 14-year period. They looked at 128 patients with oligometastatic disease. The majority had 1 to 3 liver lesions. About a third had a aortocaval lymph node. The 30-day mortality and morbidity was acceptable and not too much beyond what their primary resections were. The median overall survival was 12 months, and 5-year survival, which is a high bar, 8% for the liver patients and 10% for those the lymph node resected patients. So their conclusion with proper patient selection of surgical candidates with stage 4 is crucial. Next, there was a multi-center European study, and their title was Disputing a Principle. For a similar time period, they studied 69 patients where they resected the primary and the metastatic lesion versus 69 that were explored. It was an earlier time point, so the majority received single agent chemotherapy with gemcitabine. The median survival for this group was 6 months, and when they compared the patients resected versus the ones explored, it was 14 months versus 18 months with the improvement for the higher outcomes for patients that had the synchronous resections. Now for U.S. data, this is from the National Cancer Database. Dr. Ajaz, when he was at Ohio State, earlier or a more contemporary time period, they had over 47,000 patients with liver-only stage 4 pancreatic cancer. About 891 underwent pancreatic cancer, and then a few patients underwent hepatic resection, and there was about a 15-month median overall survival for the patients that underwent the synchronous resection of the primary and synchronous liver resection. Here's SEER data. This is from a Chinese group publishing on SEER data. Again, much longer time period, over a 40-year time period, so a little bit higher rate of removing the primaries, 3.5%, but a similar comparison for patients that were selected to have their primary removed, about 14 months median survival versus 7 months for the other patients not selected for surgery. And we've mainly been talking about synchronous liver resection. What about pulmonary metastectomy? And this is back to Germany. This is two centers, one in Heidelberg and one in Munich. They're all metachronous resections for a long recurrence. And again, mainly patients had received gemcitabine. Median disease-free survival at 18 months versus 26 months after the overall survival after the pulmonary resection. They had no perioperative mortality. These next series build in response, and so this is from back to the Heidelberg group. They looked at 100 of their liver-only stage 4 patients. Here all received FOLFIRINOX, and 43 of those patients underwent synchronous resection, and then 58 underwent non-resection. And they selected the patients for the synchronous resection based on CT response and CA19-9 response. And the patients selected for surgery had a longer median survival of 21.9 months. Next, from Verona, Italy, have this series, 2007 to 2015. And they had, all patients had a significant either a CT response or a decrease in their CA19-9, and it was 24 out of 535. And so here all the patients, the majority had received FOLFIRINOX. They had no perioperative mortality. Median follow-up was good, 31 months, and their median disease-free survival was 27 months, and median overall survival was 56 months from diagnosis. Here was a Japanese study published 2023, retrospective cohort. They followed 417 patients with synchronous liver metastasis. 10 patients had a significant response and underwent resection. 5 had synchronous primary and liver resection, and the other 5 just had removal of primary because the liver lesion was not detectable. For these well-selected patients, their median overall survival was over 54 months. What about peritoneal metastases? Here's 2 Japanese series, one in the British Journal of Surgery, the other in Annals of Surgery. First one's 46 patients. They did IP paclitaxel with IV gemcitabine and NAB paclitaxel. Median survival 14 months for this challenging group, and 1-year survival of 61%. And then the other one was with IV and IP paclitaxel with S1. They had 33 patients. Their median survival was 16.3 months. And then the most recent series, this was accepted last summer to the Annals of Surgery from Hopkins, Jin He's group. They followed 73 patients, 45 with liver oligometastases and 28 with lung oligometastases. Both groups underwent resection of the primary and the metastatic lesion. Median overall survival for the lung group was 59 months and 11 months for the surgery group. And in the liver cohort, it was interestingly, the P53 mutations were associated with the worst median survival. And so there's a nice review from Rob Martin's group summarizing some of these retrospective series and the reduction in their hazard rates in cancers, as published in 2025. So I will leave you, or I will end with some of the ongoing randomized controlled trials. There's the Chinese study group that has a multi-center randomized trial which started in 2019. There's the HollyPanc trial with oligometastatic hepatic disease, single-arm phase 2 trial with liposomal irinotecan, oxaliplatinum, and 5-FU. And then finally, phase 3 randomized controlled trial in Japan with IP paclitaxel compared to systemic treatment for peritoneal metastases, patients from pancreatic cancer. So I think I'll wrap up, and then the takeaways are for very, very select patients. It's a challenging group of patients to treat, but in well-selected patients, high volume centers are continuing to study synchronous resection or metastasis resection for pulmonary disease in this challenging group. So thanks once again for Dr. Ari, and thank you for tuning in.
Thank you, Dr. Bentram, for that very difficult topic, which he has addressed so eloquently. I request all our faculty to put on their cameras and microphones, for we are into the final few minutes of this webinar, where we select some of the questions which have been posted by our participants for our discussion. So some of them have already been answered by our experts, but there are few of these which we thought we should just discuss out once more with our faculty. I've addressed these questions to particular experts by their names, but if others have something to add, kindly feel free to chime in. So the first question is, what's the extent of lymphadenectomy for pancreatic duodenectomy? And is there any role of an extended template in this setting? I would address this to Dr. Manish Bhandare and Dr. Ari. Dr. Manish.
Yeah, so the standard lymphadenectomy template, which is described for a Whipple procedure, includes the periportal lymph node group, or the station 12 group of lymph nodes. Then we have the anterior and posterior pancreaticoduodenal groups, which are lower down along the root of mesentery. There is station 14 lymph node, which is at the root of SMA. And we have the peri-SMA neurolymphatic tissue, which also forms as a part of a standard clearance in pancreatic cancer. So beyond that, the extended terminology is used when, not to forget the common hepatic group, which is station 8 group as well. Beyond this, the celiac group or the station 16 group is also something which can be thought to be an extended lymph node clearance. It's not, I would say, a contraindication for surgery if that group is involved per se. If there is an adequate response to therapy, and then if it can be cleared completely, of course, that is to be done. But otherwise, the peripancreatic lymphadenectomy is pretty standard, and that is what is required in a standard case of a resectable or a borderline resectable tumor. Dr. Chandrakant, you would like to add anything?
Yeah, no, I agree with you, Dr. Bhandare. But I think depending on the geographic region of the world, the approaches seem to be different. You know that the randomized control trial that came out of Hopkins in late 90s showing no benefit to extended lymphadenectomy. It showed feasibility, but no benefit. I think to some degree still stands today, because I come back to what I said. Pancreas cancer is a systemic disease, and as Dr. Bentram rightly said, no amount of our technical wizardry will change the lethality of that disease. So what I would still say is lymphadenectomy within the field of resection should be done well. But anything beyond that, I know someone alluded to the triangle operation, and Dr. Buchler has come out with so many innovations. So I agree with you, Dr. Bhandare, but I think on this side of the Atlantic, the role of extended lymphadenectomy, not just in pancreas cancer, but also in esophagus and some other malignancies, is not as profound.
If there's no other input from other experts, we'll move on to the second one, which is in a margin positive disease, after resection, would you and when would you add adjuvant radiation with respect to the systemic therapy? And this is to Dr. David Bentram first, and then Dr. Ramakrishnan.
Yeah, thanks for the question. It highlights both the recurrence, the localized recurrence, local recurrence, and then systemic recurrence. And then just to echo Dr. Ari, it's a systemic disease. If it's a margin positive resection, it's at larger T stages, likely node positive. So the systemic failure is still, in my mind, probably the most impactful for the patient. So I think we should, get the full systemic course and then add radiation after that. So I would prioritize that if that was the heart of the question.
Yeah, I would tend to agree with Dr. David that you need to prioritize giving systemic therapy first. But whether to add radiation, I don't think there is enough data to say if radiation is really going to reduce your local recurrence rates in a margin positive. We agree that a lot of us tend to err on the side of giving it rather than withholding it, but I don't think we really know what is the real benefit.
The next question is the specific question we had in the chat was the role of PET-CT in reassessment after neoadjuvant therapy. But I think we didn't cross the bridge on the role of PET-CT overall and the role of staging laparoscopy if otherwise the resection is planned as an open surgery. So the role of these two, Dr. Chandrakant Arya and then Dr. Manish.
So PET-CT, we don't do it routinely unless there's something that stands out. Now, they have eminently resectable disease, but the CA19-9 is very high. Something needs to be atypical for us to consider a PET-CT. Now, staging laparoscopy, I belong to a different school. I always believe that it takes 5 minutes to do this. And this is one clinical scenario where the debate around something is way more than is needed to just do it and get it done.
Dr. Manish?
I would agree about the PET-CT part that it would be only required in high tumor marker values, locally advanced disease. It can help us in terms of assessing the response to neoadjuvant as a metabolic response, because the discussion was there during the cases that the anatomical response may not be present in pancreatic cancer. In fact, if there is an anatomical stability of a lesion, it is in fact considered as a response to therapy. Lack of progression is considered as a response to therapy. But you may see a metabolic response. So that way a PET-CT can have a role when we are doing neoadjuvant therapy, but that's not to be practiced as a routine. Individual institutions will have their policies. As regards staging laparoscopy, yes, we all know and everybody says that if you have more than 500 value of CA19-9, we do a staging lap. But in reality, somehow we don't detect the peritoneal disease so often when it comes to a pancreatic head cancer. We do have a high amount of peritoneal pickup when it is a distal pancreatic tumor or a body tumor. But somehow we don't see, even with borderline resectable and locally advanced disease, the peritoneal disease incidence in absence of a radiological imaging is, I would say, quite low, much lower than a gastric cancer or any other cancer. So while we may do it, it's a small procedure, it's a quick procedure, but sometimes if logistics are an issue, maybe it can be avoided, but definitely do it if you are dealing with a very high level of CA19.
Any comments from Dr. Bentram and Dr. Ramakrishnan?
Yeah, no, I agree. But use them selectively for both. Our guidelines talk about considering PET, but yeah, it's unless we're trying to confirm something. And I agree the same with laparoscopy. The CT scanning is better now, and it's not positive frequently. So I do try to up that by having either CA19-9, or I like the comment about the tail cancers. So I am selective with that.
In a borderline resectable, probably the role of staging laparoscopy might be more. So it might be a good idea to do a staging laparoscopy, the format even before starting neoadjuvant therapy, so that you really know what is the intent of treatment, whether it's intent or whether there is a possibility of staging and resecting.
Right. And I think Dr. Manish already alluded to this question, but would you send a frozen section of a 16B1 lymph node during resection, either upfront or post neoadjuvant? Dr. Ramakrishnan and Dr. David Betru.
I do not do it routinely. If there is a enlarged node, yes, but otherwise I don't practice from 16B1 as a routine.
Dr. Pentry.
Yes, and I agree. Same as Dr. Ramakrishnan. Do it selectively, that or even at the celiac axis between, but depending on where the tumor is, it's fine to do initially if you're worried about something. Higher risk cases, or a patient with poor performance status, maybe something to consider, but not routine.
So I think with that, we would conclude our Q&A session. I know there are a few questions, more than a few. If there's some faculty who's willing, I would request them to just hang out and address them before we end this. I would like to invite IASO President-elect Dr. Chandra Mohan to kindly deliver his closing remarks for today's webinar.
So good evening, the viewers from India, and good morning to the faculty from US. Srijan, am I audible enough?
Yes.
And in fact, I think it is a feather on the cap of IASO to have this meeting, which is a truly remarkable event. We discussed length and breadth about a very difficult disease to cure, pancreatic cancer. And in fact, I was a bit apprehensive in the beginning that whether our candidates are going to arrive at some consensus which is internationally acceptable. But I think the meeting went very well, and it not only it reflects the preparedness of our candidates, it also reflects the kind of the unity in practice across globe, which is very heartening to see. And regarding these meetings, for the information of Professor Bentram and Chandrakant Arisa, this started post-COVID with this online platforms available after COVID. And till that time, the Indian centers used to have their own teaching centers inside hospital. The starting of this online meetings really opened up a floodgate of information for the candidates across India. And as an examiner, I have seen it pretty much increased the standard of knowledge of our surgical oncology trainees. And in fact, we are so privileged to listen from experts from Tata Memorial Hospital, Adyar Cancer Center. And this meeting has been attended by trainees in every nook and corner of the country. And in fact, it becomes a knowledge sharing platform, which helped our students very well. And today, actually, they are not only listen to Indian doctors, they also listen to the experts from Northwestern University, Nebraska University, and the examiner coming from those places and sharing their knowledge. It's a remarkable event in Indian training for surgical oncologists. And we really thank Professor David Bentram as well as Chandrakant Arisa for coming forward and doing this meeting. And of course, our Indian faculty, Manish Pandhari as well as Ramakrishnan, did a wonderful job. And Ramakrishnan's presentation was amazing. And congrats to you as well. And again, the main managers of the event from Indo-American Basavatarakam, Srijan Shukla and Subramanian Rao, they need a lot of applause for conducting this meeting. And this, in fact, starts another journey in the academic pursuit of IASO. I hope more and more collaboration is going to happen. And not last but not the least, I appreciate Nivedita as well as Amit, who did a wonderful job today. And I also thank more than 100 online delegates in the meeting, as well as people watched over YouTube. And for your information, this will be permanently placed in YouTube, and people can refresh it up when you go for exams. And thank you once again for all. Have a good night from India. Good morning to US. Thank you.
Thank you so much, Dr. Chandramohan. With that, we'll conclude the webinar tonight. Our upcoming webinars will be on the 26th of May. We have the ISO Mastery of Surgery, which is the sister program to this online webinar. And the discussion continues on 26th on the technical aspects of the surgery of pancreatic cancer. It will involve video tutorials by experts from all over the place. And the topic for next month is going to be penile cancer. We'll have on 9th of June, the masterclass similar to this one. And then 2 weeks later, we'll have the mastery of surgery, which will include the technical aspects of the surgery. As said, you can find all these masterclasses from the last 6 years on YouTube. You can search ISO webinars and you'll be able to find at least 6 or 7 webinars on each organ division, which you can review them at your own leisure. So from our side at Indo-American, on behalf of Dr. T.S. Rao, Dr. Ziba Yusufi, and myself, we would like to wish you all a good evening here in India and a good day ahead in the US. And thank you for logging in. Good night.
Thank you.
Thank you, Srijan and Paul.
Thanks all.
Thank you. Thank you all of you.
Thank you. Bye-bye.